everyone. A very good evening to all. This is Dr. Sangeeta, one of the mentors for MRCPCH at StudyMEDIC. I would like to tell you about the clinical station uh, in MRCPCH. In that, I'm going to take a topic on short stature today. So let us see how we have to go about when you see a child with a short stature in your exams. Generally, for MRCPCH clinical station, the time duration given for you is 9 minutes. In that, you will be taking 6 minutes of your examination. It includes the general examination or the particular system, what you are going to get it. And for the remaining 3 minutes, you will be discussing the scenario, that means your final diagnosis or differential diagnosis with the investigation and management plan with the examiner. Prior to the station, you will be given around 4 minutes where you will be waiting outside to before going to the station. So let us look at the station about short stature. This is the mark sheet you will be getting it for the MRCPCH exam. In the first part, you will be getting 10 mark sheets for 10 stations. In that, you have to enter the candidate number, name, date, everything, this page. And the next page would be the next slide, please. To note down the mark for the examiner. In that, you will be given marks according to the physical examination, how you are approaching to the child, and are you picking up the essential findings like identification of the clinical signs, clinical reasoning. Are you justifying the findings with the examiner to make the diagnosis? And the examiner is going to observe your rapport and the communication style with the patient, whichever whomever is given to you. So the examiner will mark you as the candidate is meeting the standard, or he is having only the borderline knowledge, or below standard. They will note down the marks like this: meeting the standard, borderline, or below standard. So you should keep this in mind before uh, going for the clinical examination. Yes, next slide, please. So you can take your time to read about these things before appearing for your exams. These papers are there in the RCPCH website. So please see what they are expecting from the candidate. When you do the physical examination, it should be a well-structured, systematic examination technique. Appropriate care should be taken to make the child comfortable, and appropriate use of equipments should be needed. You should identify the clinical signs properly and correctly interpret it and discuss with the examiner. And to make your diagnosis, you should able to say the clinical reasoning, and your communication style and the rapport of communication to the parents and the child will be noted by the examiner. Next slide. So when you get a child who's having short stature, then you will be expected to plot the growth chart perfectly. It is very, very important because it is a clinical skill and you must be familiar with it. As if you have done this charting of the growth chart multiple times in the ward. You should do like that. You should be very confident in plotting the growth chart. Various growth charts are available in this website, rcpchac.uk website. You can have a look, and in that separate growth charts are there for male children and female children, and you also have certain specific growth charts for Down syndrome, Turner syndrome. If the child is more than 5 years, you may have to know about the BMI chart as well. And another point is make a dot instead of that cross, okay, to indicate the measurement, and you should not join that dot. Okay. Yes, next. So, certain cases, commonly what you can get is Turner syndrome or any other syndromes with a short stature, Cushingoid features with a short stature, you can get it as a case. So, if you see a child with a delayed puberty and short stature, how will you present to the examiner? So, some children might be giving the clue only with the uh, examination. That is a short stature girl child, webbed neck with all Turner syndrome picture. You can make the diagnosis as soon as you see the child. So how will you uh, convey the message to the examiner? I examined Karishma, who is 16 years old girl with some features consistent with the Turner syndrome. They were child is having webbed neck, posterior hairline is on the lower side, and the cubitus valgus is there, short stature is there. Like that, you can tell the findings. And finally, you would say, I would like to plot her growth on a Turner syndrome growth chart to see if the child is having normal or abnormal pattern of growth for her age. Next slide. And if a boy child who is having short stature, for example, I examined Charles, who is a 15-year-old boy with some features that consisted with a diagnosis of cystic fibrosis. So you can see any other supportive measures for cystic fibrosis like nebulization. Uh, these were on review of his growth chart. They can also give you a growth chart showing the abnormal growth pattern where you will suspect some chronic diseases like cystic fibrosis. In that case, you can say like, I would also like to plot his BMI on the appropriate chart because the child is 15 years old. There is no evidence of a pivotal growth spurt on his growth chart for a 15-year-old child, and he will need to have his puberty staged as a part of his annual review. The most likely reason for this is that his underlying condition, like cystic fibrosis, is impairing his growth and delaying his puberty. I would also like to ask his parents at what age they went through puberty. This is for completion's sake. Next slide. So what is the suggested approach? Previous slide, please. So introducing yourself as previously described, you are going to introduce yourself to the child and the caretaker, whoever is there, looking for the growth charts and looking at them as soon as you see them and decide whether the child is short for family size or not. And once the child is, you have decided that the child is having a short stature, whether the child is looking ill or well. Is there any dysmorphic features? Is the child is having underweight or overweight? Certain syndromic short stature can be associated with obesity. And you check whether it is due to the limb shortening or spine shortening, or you are noting down any disproportion. Next. Examination directed towards finding and underlying chronic disease process that may have impaired growth. For example, cystic fibrosis, bronchiectasis, celiac disease. You can see the wasting of muscles, inflammatory bowel disease. You can see mouth ulcers, or if the child is on nasogastric tube, you can pick it up. Insulin-dependent diabetes mellitus. Look for any lipoatrophy, lipohypertrophy, which will impair the growth if it is poorly controlled. Next. A child who's short, well, but looking well, and the child is normal or overweight, then look at the growth pattern if the growth chart is available, and look for any endocrine disorders like Cushingoid phases, hypothyroidism, Always look at the neck for any evidence of goiter, hypopituitarism, or growth hormone deficiency, in which they will have central obesity and characteristic mid-facial crowding will be there. It may not be always obvious as well. Next. So you have to offer to measure the height and including the sitting height. If you suspect a skeletal dysplasia, check the weight, head circumference, and if appropriate, subscapular, triceps, skin fold thickness, and pubertal stage, and plot on appropriate centile chart, whichever is given to you. You may be asked to plot growth velocity also on the relevant chart. These growth velocity charts are available in the RCPCH website. Please have a look. That is very, very important for your exams. Next. Coming to the disproportionate short stature of limb and spine, ask them to extend the arm down lateral side and consider limb shortening if they do not reach the mid-pelvis in infancy or the upper thigh after infancy. Consider spine shortening if the arms extend well down the upper thigh. Examine the arms for rhizomelic. Proximal, ask them to keep it like this, and you can find out whether it is a rhizomelic shortening or mesomelic shortening or symmetrical shortening. Fully flex the arm at the elbow and compare the upper arm with the lower arm. Extend the arm and examine for the carrying angle, like in Turner syndrome, where you can pick it up cubitus valgus. And examine the hands for hypoplasia, hyperconvex nails, again in Turner syndrome, short fifth metacarpal in Turner syndrome, and pseudo hypoparathyroidism. Next. Look at the spine for kyphosis and scoliosis. How will you do it? Ask the child to bend over as a part of the scoliosis examination and look for the spinal abnormality. Any evidence of spinal surgery or back braces, you can pick it up. Look at the lips for joint contractures as well as scars. And also to completion, you have to check the head circumference. Next. And also look at the parent's size. Is there any dysmorphism or limb disproportion? And think about mid-parental centile and offering to plot the parent's height. Wherever it is relevant, don't forget about the development. But finally, you can add this point to the examiner when it comes for the discussion. If dysmorphic features are found, remember other systems, particularly cardiovascular system. So once you make the diagnosis of short stature, possible syndromic or endocrine causes or some other chronic diseases, either it could be cardiac or cystic fibrosis or some renal problem, properly do the examination to find out any clues, and then you are going to discuss the investigations as per the diagnosis you are making. Commonly, if you suspect a dysmorphic features with the short stature, then you may have to discuss about the chromosomal analysis, white cell enzymes analysis, bone age, skeletal survey are all useful to make the diagnosis depending upon the examination finding. Remember the cardiac investigations like echo if you are finding anything abnormal, and renal ultrasound, audiology, ophthalmology if looking for associated anomalies in that particular child. Next. So while you summarizing, finish the examination by offering to plot the parental height and calculate the mid-parental centile as well. You should get prepared to discuss further investigations for chronic diseases. Depending upon the disease, you may have to discuss about sweat chloride test, cilia screening, urine dipstick, etc. Or endocrinopathy related disorders like thyroid function test, urinary free cortisol excretion, insulin-like growth factor 1, etc. Bone age may need to differentiate it is familial short stature or constitutional short stature. Next. If a spot diagnosis is obvious or strongly suspected, like in achondroplasia, Turner syndrome, then direct the examination towards identifying the associated physical characteristics and looking for complications. So you know about Turner syndrome or achondroplasia, what are all the complications you are expecting. If there is no obvious cause, you couldn't find out anything, and whatever positive findings you are seeing in the child, you please describe that properly to the examiner and discuss about the possible differential diagnosis with the examiner. That would be ideal. Next. Next slide. So, what are the causes of limb and spine disproportion? You have rhizobilic shortening, mesobilic shortening, non-rhizobilic and mesobilic shortening conditions, mucopolysaccharidosis, asymmetrical limbs in case of chondrodysplasia punctata, hemihypertrophy, like Russell-Silver syndrome, short spine only in case of spinal irradiation. Then finally, you have to discuss about getting the past details. Next. And apart from that, the familial short stature is possible. Chronic disease process cautions causing short stature. Endocrine causes, as I already discussed, hypopituitarism, Cushing's, hypothyroidism, precocious puberty. Syndromic causes like Turner's, Noonan, Russell-Silver dwarfism, Prader-Willi, Carnelia-Lange syndrome, many syndromes are there, so you can have a look at that. And constitutional delay, emotional deprivation, and neglect are the rare causes of short stature in children. Next. What is constitutional delay? This is the most common cause of delay in puberty. It's more common in boys than in girls. On the growth chart, slowed height velocity, which leads to height crossing the centiles downwards. There will be a family history of pubertal delay. Pre-pubertal levels of LH and FSH would be useful, which will be low, and a delayed bone age also will be visible on the X-ray. You make sure that there is not a chronic disease process going on in the child, and the child is not syndromic, like pituitary thyroid problems contributing to short stature. In girls, Turner syndrome need to be specifically excluded if they have short stature. Next. While you interpret the bone age, where will you expect a delayed bone age? In case of increased cortisol, emotional deprivation, decreased androgen, poor nutrition, growth hormone deficiency, chronic disease, Turner syndrome, constitutional growth delay will cause delayed bone age. Whereas you will get advanced bone age in case of increased androgen and estrogen, precocious puberty, hypothyroidism, cerebral gigantism. Normal bone age will be there in familial short stature, increased growth hormone, and in case of obesity. Next. A word about Turner syndrome. Generally, you will be looking for the uh, clinical features and plot the growth. Some common clinical features would be edema of the hands and feet in neonate, but you are not going to get the newborn baby. But if the examiner asks, you should be able to tell all the clinical findings, starting from widening of carrying angle, no posterior hairline, prominent ears, neck webbing, shield chest, widely spaced nipple, delay in puberty, and axillary hair development might be delayed in children who are having Turner syndrome. Next. Also look for thyroid status, cardiovascular system, in particular forelimb blood pressure. If the time permits, at least you can say that you would be checking for the blood pressure while you do the examination. You need not waste your time by doing the BP measurement in MRCPCH exam. But you can tell the examiner that you will check it. Abdomen ultrasound only will tell you about the associated harsh kidney. Formal audiology and pubertal staging would be needed in children who are having Turner syndrome. So finally, if you get a Turner syndrome, you will present like Sarah is a well-looking girl who appears short for her age. And I would like to plot her height and weight on a central chart. Examination reveals webbing of her neck, cubitus valgus. She has a short fifth metacarpal and dysplastic nails. The most likely diagnosis is Turner syndrome. I would like to examine her cardiovascular system and stage the pubertal development. Next. Then the management involves regular follow-up. What are they? Screening for congenital anomalies, including cardiac and renal anomalies. Estrogen progesterone replacement would be needed in children who are in the adolescent phase. Growth hormone replacement therapy is needed in children who are having Turner syndrome, and it is approved for children who are having Turner syndrome. Monitor for complications including hypothyroidism, hearing loss, hypertension, scoliosis, insulin resistance, neurodevelopmental difficulties, and amblyopia. Next. So this is about Turner syndrome. Like that, you have to prepare for certain other common conditions like chronic disease, other endocrinopathies, and familial short stature. And you should be very familiar with the plotting the growth charts in growth velocity charts and BMI charts. And overall, you should be able to discuss your differential diagnosis with the examiner. Hope you have an idea about the clinical station short stature. Thank you for the patient listening. Thank you.